ask you to explain where we are these days with Big Sky.
Sure.
Thank you for joining us.
Oh, you're very welcome. Well, good morning. I know lots of you on the call, but there's several I don't. So I'll introduce myself, and we've got a couple other folks from our team with us today. We're going to walk through kind of an update as to where Big Sky Care Connect is right now. I'm going to do not an undemo. I can't call it a demo because they don't actually allow me to do real demos. They know me well enough now and are aware that that's probably not the best idea, but they do give me slides that I'm allowed to present on the demo. The person who usually leads our demos lives in California, and I thought asking her to get up at 6 in the morning might be a little bit much to ask. So we'll walk you through kind of a little bit of a demo of what our software platform looks like. It's up, live, working today. We just completed our first round of funding with CMS, and we'll talk a little bit about kind of where we are from a funding and sustainability standpoint moving forward, and give you an idea of kind of where things are at. So, so I'm Ben Tyrell. I'm the CEO of Big Sky Care Connect. Been in this role since May of this year. I've been involved in this project for over 2 years. Served on the board, the founding board for the organization, and then served as a consultant for several months, as Dave brought up. And in my past time presenting to you is in my role as a consultant, working with the team here to get live and get things up and running. With me today, Jack Daniel is our Director of Partner Success, and Krista Pierce is one of our Partner Success Managers, and she actually will be the one kind of having responsibility for the Billings market. So for those of you that do participate, you will get to know Krista quite well as we go forward. Let me bring up my screen here. Hopefully you can, is that coming up for everybody?
Yes.
Make sure. All right, great. If you have questions as we go through this, please feel free to ask. We want to make this as formal as possible, or informal as possible. So walk a little bit. So introduce Jack and Krista. I'll talk a little bit right now kind of about a current state of where Big Sky Care Connect is and where we're at. So we are Montana's HIE. We were designated in 2019 by Governor Bullock as the designated state health information exchange for the state of Montana. And our goal has been to build connectivity to providers across the state. And when we speak of providers, we look at providers as basically anybody who delivers healthcare and has an electronic health record. We want to partner with your organization, your providers, receive your information, share it with other providers in the state, and allow you access to that information from other providers. In addition, we work very closely with the state of Montana, with the Montana Medicaid team, to bring state level data and state registry data, Medicaid data into our platform also. So the general idea and goal for an HIE is to provide a single point of access for longitudinal patient histories across providers and across time. The goal really from our perspective is to support organizations in meeting the quadruple aim. We want to improve patient satisfaction and patient outcomes. We want to improve provider outcomes, provider satisfaction. We want to improve efficiency and improve cost over time. And really try to get information delivered to the point of care where it's needed in real time as close as possible. Organizations in other states that have participated with HIEs have been able to realize significant improvements both in clinical outcomes, reduced readmissions, reduced reproduction of tests, improved efficiency across a lot of different spectrums. So why Big Sky Care Connect? For those of you who've been around the provider world in Montana for a while, we are not the first attempt at an HIE in the state of Montana. Where I think at this point, probably the third. We have been able to learn a lot from past attempts, and past attempts were done on a statewide level with HealthShare Montana about 10 years ago. And then another attempt actually that spawned a lot out of the Billings Care Transition Coalition was a partnership between Blue Cross Blue Shield, Billings Clinic, Riverstone Health, and St. Vincent's to try and create a regional HIE to deliver on that. So we've been able, through our growth and learning, to learn from those endeavors, as well as the fact that for better or worse, Montana is the 49th state, there are only 50 still, to attempt and implement, fully implement an HIE. So we have taken the best cases that we can from those endeavors and really work to build across that platform and expand our capacity to what we do. And the good news is we have achieved the principal success point for us is building an electronic master patient index. So that goal is to be able to identify a patient to the right individual across providers based on the information we can collect from them. Has been the biggest struggle that prior endeavors have had, was to be able to deploy a technology that was actually able to deliver on that. And we've been able to complete that. We had our first providers go live contributing data to us in December of last year. And we'll talk through the numbers on here. The 83 participants with 185 locations and 300 is not quite up to date with where we are today. So I have a little bit of a slide coming up here that'll kind of walk through kind of where we are. So if we talk about the actual technology footprint that we have in place today. So we start collecting clinical data directly from participants who sign on and work with us. We work very closely with those participants, with their EHR vendors, to build connectivity that works for them. We have a lot of different technology platforms we use as far as how we manage that connectivity and what feeds and how we can receive information. A lot of different ways we can work with that. That creates the kind of first feed of data that comes into us. The second feed, we've partnered with the Montana Hospital Association and an organization called Collective Medical, who's a nationwide organization that does two different things that are very prevalent for us. First, they provide an emergency department alerting service. So they work nationwide to collect data from hospitals and from emergency rooms on their patient events as patients register, have experience there. They have an algorithm that looks to identify at-risk patients within those populations. So drug-seeking patients with violent histories, patients who have multiple visits to ERs within windows. And as a patient is registering at an ER, they're able to deliver an alert directly to the ER to give a little bit of a history if there is a patient that has a relevant history within that algorithm. The second piece that Collective Medical does, they were purchased last year by Point Click Care, who is the nationwide leader in delivering EHR services to nursing homes across the country. And in Montana, they serve probably, I think it's about 70 or 71 of the 76 nursing homes in the state. And we have built out a process with Collective Medical where we will be able to interface nursing homes through the Collective Medical portal from their Point Click Care enterprise with no effort, no cost to any of those nursing home facilities to participate with us. So that's our second feed. The third feed we get is another nationwide organization called Doctor First, who works directly with pharmacies to receive prescription information on medications for patients. And the really great thing they provide is not just the prescription history, but the fill history. So providers are able to see through that, not just what a patient has been prescribed, but what they have actually filled and retrieved to work through. eHealth Exchange is the next. They're another national organization that allows us connectivity to other state HIEs. So we're working right now, our first connectivity will be with North Dakota. So we'll be working to build connectivity and connection points to receive information on patients who come to receive care in Montana who may have a history of care in North Dakota. Once we get that complete, we'll be adding South Dakota, Utah, Colorado, Oregon. Sorry about that. Getting phone calls this early in the morning. The other opportunity we have through eHealth Exchange is bringing information from the VA and the Department of Defense. So we unfortunately don't control the timeline of when that information will come to us. We are sort of at the mercy of the VA. So we've been waiting. I think we submitted our initial request back in the beginning of this year. We were hopeful that August was our original timeline for them to get to us in the queue, but we've not received our notification that they're ready to contribute with us. And then finally, we're receiving Medicaid claims data. And the data we receive on the claims is purely clinical. We do not receive or store or manage any financial information within our repository. So the information we receive from Medicaid is the clinical information based off of their claims, as well as their eligibility file. So one of the things we'll be building out is access to Medicaid, real-time Medicaid eligibility information within our portal. All of that information feeds into our central repository. So partnered with a company called InterSystems and their HealthShare product, which is an internationally recognized leader in this technology. That's where our master patient index is built through. So we receive information from all of these participants, all of these locations. We're able to process that, match it to the right patient record, and then provide that information back to providers. In addition, we can take that information and provide event notifications. So we can customize event notifications for providers if you would like to know on a panel of your patients what their history is, or if they have an event, an admission to another hospital, a discharge from a hospital, if they registered in an emergency room, admission to a nursing home, any kind of trigger points like that, we are able to build out an event notification and be able to send you a notice either through your electronic health record or through a direct secure messaging service to let you know that an event has taken place with one of your patients. We then have built on top of that data repository now a data analytics tool for those who are interested in population health, for quality endeavors, regional quality endeavors like the Care Transition Coalition. We're able to take all of that data, de-identify it when needed, provide access to providers to be able to look at population health history, population health outcomes, not just across your organization's experience with that patient, but across the totality of that patient's experience with the healthcare system. And that right now really kind of that's the footprint of what we have in place today. We're in the process right now of working through the proposal process, identifying a partner, and we'll start the contracting process here probably in the next month for a diagnostic image exchange platform, which will allow providers to access the diagnostic image and pair that to the professional read report from the radiologist or the provider across entities, and be able to review that either in a cloud-based platform or, if desired, to download that image into their native system. And then we'll be working with several of the private payers in the market, Blue Cross Blue Shield, Pacific Source, Mountain Health Co-op, on bringing in the clinical records from their claims data into our repository also. Let me see. And then here. So what we have available today, we have a longitudinal clinical record with the existing data repository. The master patient index is working. We have a clinical portal. I'll walk you through kind of what that looks like today. Our population health and analytics quality measure platform. The data sets we're receiving from organizations, we start every organization with the admission discharge transfer records and the associated demographic and clinical information that we can gather from those. We then add on top of that lab feeds, radiology, medications, transcribed records, and continuity of care documents. We have a direct secure messaging platform. So if you do not have access to a direct secure messaging account, which will allow you to communicate securely and communicate PHI across an electronic medium, we have the ability to deliver that at no cost beyond the membership fees of participating with us. Coming soon, we talked about the diagnostic imaging, the Medicaid live real-time Medicaid eligibility. So we'll be receiving the same eligibility file that Medicaid processes on a nightly basis for their online portal. So within our patient record, you'd be able to get a look at a patient's current Medicaid eligibility as well as their historic eligibility. working with the state to build out registry access for labs, public health reporting, Department of Corrections, whole host of other information that we are starting to build out. We do have connectivity in place with behavioral health organizations, Youth Dynamics, Rimrock Foundation, and several other organizations across the state that deliver behavioral health services. We have restricted access to certain parts of those records, so records that fall under the 42 CFR Part 2, as well as some of the state mandated sensitive data around sexually transmitted diseases. We do hold those records. They are restricted and require specific access within our system from a user base, as well as verification of authorization from the patient or the patient's representative to view those records. So where are we today? So as of September, so this is as of September 30th. We have added one additional organization contributing data this week. So we have over 300 facility locations across the state that have signed on to participate with us. 188 of those are currently contributing data. We have over 500,000 unique patient records within the repository currently. You can see almost 1,000 users of the system. 762 of those are clinical users. 193 of those have completed training with us. We do offer training ourselves. We do train the trainer and a host of other opportunities for folks to learn about the system. And we've processed 7.2 million points of data on patient records over the last 10 months. So how we've kind of grown and kind of get a sense of what's happened, a lot of activity in, from our go live back in December. You can see not a lot of logins, and then some growth over the course of the year, and then a big spike in August and September this year, which is when we had a number of our larger accounts go live. So for Billings Clinic was our first contributor back in December. SCL Health went live with all of their sites. So Miles City, Billings, Butte, hospital locations, as well as all their outpatient locations started contributing mid-September. Riverstone Health is in process of integrating right now. We hope to have their integration complete by the middle of November is kind of the timeline that looks like right now. Seeing our number of users kind of growing, the number of trained users. We offer training on an as-needed basis for every account, as well as some scheduled training throughout the week. And then we're starting to look now at which facilities are utilizing the service. Jack and Krista and their team work very closely with our partner organizations to help roll this out within your organization and determine how to best who your best users are, how do we train them, how do we work with them, make sure they know how to access the right data. So we spend a fair amount of time now taking a look at who's logging into the system, reaching out to them, making sure they know what the data points are, how they access it, what they can gain and work for their workflow to get through. This just gives you a little bit of a map lookout of where kind of our footprint is across the state. From a large partner standpoint, Logan Health, which is Kalispell Regional in Kalispell, Providence St. Pat's in Missoula, Billings Clinic and St. Vincent's in Billings are kind of our four biggest hospital partners. We are working very closely with several others to get them connected. We have a few big hospitals in the state that are in the process of replacing their electronic health records. So they're not really at a point in time right now to be able to engage in an integration process with us. But our hope is over the next year to 18 months, we'll add the rest of those hospital groups on. Number of other clinical, so I get a kind of an idea of the different kinds of organizations we work with. And again, our goal is to work with anybody that has a health record or a need for health record access.
Hey, Ben, speak to the VA and where we are with them. That's been a question.
So the VA is a process to work through. So there's a couple of different streams of access to that data. The main one is through our membership with the eHealth Exchange, which is a nationwide integration platform for organizations to share medical data with them. And that's the VA's chosen path to do that. The process is you basically send notice to the VA that you would like to partner with them and receive their information, and you get placed in queue for them to determine when they're ready to begin that work with you. I think I'd said earlier, we started that process the beginning of this year, sending our notification in that we want to get into that queue. We were originally told our touch point to expect feedback was August. We're now at the end of October and have not received our notice that they're ready to work with us yet. We continue to reach out and let them know that we're ready and waiting. In talking to other states, that process can be anywhere from 10 to 18 months, somewhat dependent on where the VA is at in other integrations they're working on and where that process is. So we every month we expect and hope that we will get the tap that they're ready to work with us. We have the pipeline built through eHealth Exchange ready to receive that data once they're ready to submit it. We are looking at other ways to connect with the VA, also with IHS facilities and Department of Defense. So I talked a little bit, we're looking at the image exchange platform. There's some potential opportunities for us to work with a vendor that the VA has chosen on that front. So we are looking at opportunities to do that also. That cover, yeah, Jack, if you can watch the chat for me, that would be great.
Ben, we had a question asked, is it similar, is the VA similar to, yeah.
Yeah, so yes and no. IHS does not have the same centralized infrastructure in place at the federal level that the VA does. IHS is a state-by-state level. Unfortunately, we have been very close communication with IHS. They're active members of our board. They are in the process of an EHR integration in Montana also. And so it's a bit of a challenge right now for them they're just not at a place right now to be able to make that connection work. As soon as they are, we will be actively working with them to build that connectivity out. Let's see. So our next kind of 2-year strategy of where we are, you'll see in each of these years, our first bullet point is exactly the same, which is growing out our clinical data repository. That's the foundation of what we do. We need to build more connectivity to more participants. For our current participants, we want to partner with them to bring more data and more complex and more real-time data into our repository to be able to share. For this year, we've completed our provider portal, our analytics, the direct secure messaging, kind of the infrastructure we have is in place and ready to move forward. That last bullet point of finalizing our Medicaid claims and eligibility integration, we're working on right now. For next year, the Diagnostic Image Exchange, completing that regional portal for regional HIE partners in other states, connectivity to the VA and Department of Defense. IHS would be included in that kind of process also, but slightly different. Working to integrate the private payer claims data, and then building out patient-centered data home is a nationwide repository of a number of HIEs across the country and other data providers to create a bit of a national database with basic patient information accessible within that. And then beyond that, we have a number of other use cases we've looked at and considered. We're going to hold off a bit until we get through kind of that middle green set there and make sure we've got those in place and working. And then we'll work with our participants to identify where there's strategic value in working on other use cases and other value we can bring to them. So I'm going to take a quick pause there.
Ben, we got 2 questions for you. How about Sanford Health? They want to know if in both Montana, North Dakota, and South Dakota, will they be joining?
Yep. So Sanford Health, our platform is for Montana-based providers. So if they have a physical footprint in the state of Montana, we absolutely will reach out to them. most likely for Sanford will receive their information through the North Dakota HIE and the South Dakota HIE participation. If they have Montana locations and they would like to participate with us, like I said, we will work with anyone. We typically do not look to onboard out-of-state organizations or out-of-state clinics into our platform. We partner with their state HIEs to bring the data in that way. The one exception we have looked at and would kind of impact the Billings market is for Billings Clinic and SCL Health, who both have pretty extensive and growing footprints in Wyoming. If they have an owned outpatient practice that is in that state, that's out of state, but is part of their network, is part of their EHR and flows through the existing integration we have with them, we will receive that data. But we do not look to partner directly with out-of-state providers. Again, our goal would be more to partner with their state HIE and bring in the information through that manner.
Okay.
Another.
The second one is, does the platform contain information about social determinants of health, advanced care planning, or is it more about hard data?
Right now, it's more about hard data. The social determinants of health, I saw Keely's on here from a care management, and for there's certainly a future case for us to look at both advanced care planning and social determinants of health as use cases and data for us to bring together and to integrate to providers who may be outside of the traditional healthcare spectrum, but do impact patient outcomes and positive living for our citizens and for residents of the state. We're just not at that point yet to be able to roll that out or bring that to bear. We have a fair amount of work to do with our participants and with the state to identify what kind of the right path forward is there. We work with a number of other HIEs across the country who are a little more advanced than us. We're kind of view us right now as those of you with kids as preteens. We're kind of growing into ourselves a little bit, but we're not quite there yet. There are a number of other HIEs who have been at this for 10 to 20 years, who have a little bit more of an advanced footprint and been able to identify really strong use cases and products to be able to bring to bear on some of those challenges. And we're working closely to identify what's worked and what's not worked on those endeavors.
Ben, one more thing. Are you going to present Dr. Arbogast's testimony?
I don't know. We'll see what we have for time. I have
Okay,
it in here. We'll see what
Catherine put in the chat box. She'd be curious to hear from a provider who's been.
Well, we'll see.
Okay.
See how quickly I get through the. So what I'm going to show you here is screenshots of our actual platform. I actually hate doing this. I hate when vendors do it. I hate we actually, when we do our RFPs, we tell the vendors who are demonstrating for us, we do not want PowerPoint snapshots of your product. We want to see your actual product. But it's the best I can do right now because I'm not a really capable user to be able to walk you through the system. But so this is real actual snapshots of the actual platform. It really does work. If you're interested and you would like, we can certainly schedule a time to have Krista, Jack, and Jeanette, who does a lot of our clinical training, be able to sit down and kind of walk you through the product in a live environment and show you what it actually looks like, so you can prove that it really does work to go through. So the main screen, it's really a pretty simple and intuitive user interface. Works very much the same way all of the EHRs that we've used or currently use work. You have a couple of different ways you can search. If you know the medical record number for a specific facility, you can search off of that medical record number. You can search off of the patient name and demographics. At the bottom, you'll see there's a couple of different override accesses, particularly for access for patients who have, one of the things we didn't cover is participation from a patient level in our repository is based on an opt-out model. So everybody is included unless they actively choose to opt out. As we work on integrating and onboarding providers, we work through that process with you so you can educate your patient population as to what what their options are and how they can opt out. We have a number of different ways for patients to opt out, both electronic, online forms they can fill out. They can actually do it directly through provider EHRs if that's a choice. So we have a number of different ways to do that. If they do opt out, that does not mean we don't collect their data. It means we hide their data behind glass, we call it. So from an emergency perspective, there is the ability for if someone's in an emergent situation, for a provider to be able to access what records and what information we have. The other reason we collect the data is if they choose to opt in the future, we have their historical data available to be viewed. It's also the way we restrict and hide that 42 CFR data, which is mandated at a federal level, as well as sensitive data at the state level. So there is the ability to do that override as you're searching for that patient if you have the right access. And that again, there's a user access role that's defined at the facility. You would define for your staff who are participating and becoming users. You get to identify who has the ability to access and search that data. Once you get the patient record and you enter that information, you'll get a list of different patients to come up. You'll also, on the right-hand side, you'll see the icons. That will show you the kinds of data that are available for that patient record and what has been flowing through, to give you kind of a snapshot view of how much data might be available for them. Very nice and easy scroll process. You can click to see what the different icons mean from a legend standpoint. Once you access the actual patient record, you'll see on the left-hand side, it's laid out with a series of tabs to give you the detail information. At the summary level, you'll get a little section for each of those areas with the 5 most recent values that have been received for that patient. So to give you, again, just kind of a snapshot view, at any point in time, you can click in on the details section to be able to look a little more closely at that area. If you want to look at a specific diagnosis, you can click on it to get more details coming within that. That top left corner, that's the access point. If that patient had sensitive data within their data set and you wanted to be able to access it, you can click on that to determine whether they have any data in there and whether it's usable. Again, you need to provide a second authorization point to verify that you have authorization from the patient to view that record. Once you're viewing the data in a detail level, as you look on the left-hand side, if you see a blue bar next to the tab, that'll tell you that there is data available in this section. So if you look through here, you can see there's no immunization or vital sign record captured for this particular patient, but you can see the other information. You click on the section to expand out what the data is behind that. And again, you can click on any of those levels to find it. If you're looking for something in specific, you can do a free text search within the text bar at the top. You can sort in different ways. So a lot of different ways to help you find information as you work through that. Again, give you an idea kind of what that patient data can look like. You'll see what organization submitted the data under facility, so which hospital or clinic or where that information came from. Diagnostic studies. Right now, we do not capture the images. That's the platform we're working on right now to identify our partner for, but you do get the report. So for those organizations that submit a radiology feed to us, we get the professional report from them. You're able to click on that and pull it up in a separate tab. You're able to download, you can print these to a PDF. If you have the ability, you can download them to your EHR, or download and then re-upload to your EHR if you're coming through our portal. We do have organizations that are doing more direct integrations with us where it's a little bit different as to how they view this information depending on how they interface with us. If you're looking at labs, you can look at labs in a couple of different ways. You can look kind of the longitudinal history again by date. There is a cumulative option. So if you click on the little C where in a lab test where you have multiple examples, it will bring it up and you can view it in a graph format. You can view it in a data format to be able to look at the kind of cumulative history for that patient with that particular lab test. And that would not be, they could have had that test at multiple different organizations. That is not just from one organization, but if they've had that same test across different places, you are able to view that in a cumulative setting. And finally, the patient summary, again, that is something that you can generate a summary document if you want to do that in a single kind of document set to be able to either view, to upload into your EHR. You can email it if you have a direct secure email account. You can email it directly to yourself from the chart, or again, you can download it as a PDF file to do that. Well, we'll pause Steve there for a second.
Yeah, there are some more questions. And David suggested maybe leaving 15 minutes at the end for questions, but I don't know, we can see if maybe there's time for that versus Arbogast but one of the things David asked Ben was to discuss the array of organizations that are actually eligible to become a participant with BSCC. So
what we do, I'll do a couple of those questions and then we can see where we're at and what folks want. So array of organizations is literally, we are onboarding everything from home care hospice organizations, outpatient clinics, pharmacies, behavioral health centers, federal qualified health centers, hospitals, nursing homes, chiropractor offices, EMS services, state medical examiner, county coroner's offices. Like I said, I think at the beginning, if you have an EHR or a need for EHR information, we want to work with you. There really is it's hard to identify an organization that we would not want to partner with. And are working with right now. I see they have the cost. So I'll tell you, Canada is not involved. At this point in time, we do not have connectivity at an international level. From the cost standpoint, so it's dependent on your organization type and the size of your organization. So for trying to see who's if you are a physician practice or a clinic or a hospital, it's based on the size of your organization and the number of basically billing providers that you have within that organization. If you are a nursing home, pharmacy, assisted living facility, not a physician-driven provider organization, it's typically a fixed cost that ranges between $480 and $640 a year to participate. So we have worked very hard for those types of organizations to keep the cost very, very low. It's very hard to find access to technology this powerful for that cheap, I would say. Dave, what would you like to do? So we've got about a 10-minute presentation from Dr. Stephen Arbogast on kind of, he's one of our guinea pig users of the system, and he kind of walks through his experience from a provider perspective, very much a physician provider perspective for how he's utilizing it.
Let's hear from him.
All right, well, let's see. I don't know if I've done this over. Can you guys hear that?
No.
So let's see if I can figure out how to share audio. That could get interesting. This is the first time I've tried to share this over share sound. Here we go. Let's see if this works.
Arbogast. I'm a neurologist. I have been practicing at the Billings Clinic for about 12 years here in Montana. I also spend a half day a week at the Advanced Care Hospital of Montana. Both of these regional as well as state referral locations have allowed me to see a variety of neurologic cases from all parts of the state. I have the opportunity to see patients who are neuromuscular cases with rare diseases such as ALS, as well as very complicated cases at the Advanced Care Hospital of Montana. Oftentimes access to records can be quite challenging with these cases, and I have found so far that the health information exchange has been beneficial, and I look forward to using it in the future where I think it will be even more beneficial. Physicians have a tendency to like to speak towards cases, so I brought a couple for you today, one showing the benefits of the HIE and the other showing where the HIE would be beneficial. My first case is about Mr. Jones. Mr. Jones is a 53-year-old male. He lives in Bridger, Montana. In August of this year, he showed up to the clinic in Red Lodge. He saw one of the physicians there. He was very hypoxic and short of breath, and so they essentially sent him down to the emergency room at Beartooth Billings Clinic for further assessment. There he was diagnosed with COVID and eventually transferred to St. Vincent's Healthcare. During the St. Vincent Healthcare hospitalization, he required intubation because of persistent respiratory failure. Unfortunately, we're not able to get him extubated in a meaningful time, and eventually he had to be transferred to the Advanced Care Hospital of Montana, where he underwent a tracheostomy. Unfortunately, at Advanced Care Hospital, while he had the tracheostomy, he underwent a seizure, and that is why I was consulted. The seizure consult took me quite some time to get through records. I had access to the discharge summary from SCL Health. Unfortunately, it really didn't say anything about his past medical history due to the nature of the transfer that was rather acute. I logged into SCL Health to see if he'd been seen in their Epic system previously, and unfortunately there were no records there. And eventually I logged into the Billings Clinic Cerner system and looked to see if there was any records there, and I did not find anything other than from the emergency room visits. So I was very limited on what I could look at and how I could figure out why this man had had a seizure. Now, what I did next is I actually logged into the HIE, and this has actually been part of a practice that I've been doing over the past several months. Interestingly, on the HIE, I was able to go into the Doctor First section where I saw that this patient had been on Keppra for several months, and he had been prescribed that through a Riverstone provider where he is seen at the Bridger Clinic. Unfortunately, I didn't have access to Riverstone records, nor do I honestly have time to go through another login. So I was able to see that this patient had been on Keppra. We restarted that medication. Once the patient was eventually able to start talking with a speaking valve, he was able to tell me that he'd had seizures for many years and had moved up to Bridger from Oklahoma, where he had been seen with neurologists in the past. He's back on his medication now, and there have been no further seizures. So that's one case that really demonstrates how a centralized depository of information is incredibly helpful. It could have saved me a lot of time had I gone to the HIE first, and it will be more helpful in the future as we get more and more records and data points into it. The next case is another case who I saw at the Advanced Care Hospital. Forgive the eponym, it's Mrs. So I know the
Oops, sorry about that.
Smith. I'm quite creative with my naming. Mrs. Smith just recently moved to Billings from Helena. She's homeless, and she was hospitalized with sepsis due to a sacral wound that had gotten infected. She's been weak for a long time, and it was really difficult to get any sort of history from her. She was septic, which means she was incredibly sick, and she was intubated and had a hard time, again, getting off the ventilator, which is why she was eventually transferred to the Advanced Care Hospital of Montana. Now, Advanced Care Hospital consulted me because of this persistent weakness.
was able to get very little history out of her, but I was able to get to the fact that she'd seen a neurologist in Helena. So this is where things always get complicated, and this is real world and why it's such a challenge for those of us that provide this level of care. So I know the only neurologist in Helena is Dr. Clark, and so I had my office staff at the Billings Clinic reach out to Dr. Clark's office to try and get records. It took about a week before they finally arrived. Meanwhile, the patient sat at Advanced Care Hospital of Montana. The history suggested the patient has had some sort of neuropathy as well as some sort of memory issues. The memory issue is the reason why Dr. Clark was evaluating this patient, and so she really didn't spend much time on the neuropathy. So therefore, I was able to see, though, in her notes that the patient had been seen in Kalispell several years before. Now, I didn't have any of the Kalispell records. Dr. Clark's office didn't seem to have them or did not forward them on to us. And so once again, I had to have my office staff forward record request on to Kalispell to try and get records to find out what was going on in Kalispell. In the meantime, this patient had been sitting in the hospital for several weeks, and we did have to try and do a more workup to figure out what was going on. This was a relatively expensive workup, as many neurologic workups are. This included aggressive lab work, repeat MRIs of the brain, neck, and thoracic spinal cord, as well as an EMG and nerve conduction study trying to clarify if there was some sort of neuromuscular cause of the weakness or if there was something going on with the brain or spinal cord causing this persistent weakness. Unfortunately, the workup was not very revealing. Fortunately, however, we finally did receive records from Kalispell that suggest this patient has a condition called CIDP. That stands for chronic inflammatory demyelinating polyradicular neuropathy, and you can go home and use that word over dinner tonight and talk about how great you've experienced neurology. So CIDP is a treatable condition, and we were able to treat this patient, and which eventually allowed us to get him off the ventilator and send him back to a more long-term rehab facility and hopefully get more independence with time. So these are both just a couple of demonstrations of why the HIE has been helpful and where it could have been helpful. Thank you for taking the time.
All right. Well, that pretty much covers our presentation and kind of where we're at. Are there other questions or other areas you'd like us to get into, Dave?
No, you've done a great job of covering everything, Ben. I guess the question is, we've got most of the people that are on the call today are from the Billings area, but there are people from where. What's the onboarding process? How do people actually connect?
Sure.
Big Sky Care Connect if they're interested?
So the first step is kind of, reaching out to our team. We do have a contracting process that we go through, and a participation agreement as well as a business associate agreement. The good news is those agreements have been vetted from national attorneys, local attorneys, state level. They're very comprehensive. The bad news for some organizations as we work through this is we do not edit or change them for anyone, regardless of the size or scale of organization. So every participant that signs on with us signs the same agreement. And that covers a lot of the security infrastructure, the access infrastructure, how responsibilities are laid out for providers and members of our organization to engage and participate with us. Once we complete that process, we go through a technical review. So we have kind of our Jack and his team, and then our technical team will start to work with your organization, identify what your EHR vendor currently is, how they integrate. So a lot of those onboarding and the technical interfacing side becomes dependent on the different electronic health records and what their capabilities are. For a number of organizations, we have what we consider a hub interface build. So for example, with SCL Health and with Billings Clinic, we built out connectivity to Cerner for Billings Clinic and Epic for SCL Health. Any organizations that utilize basically that sub-license their EHR services through one of those organizations, the interface is already built. We just need to contract and work through the process to activate the connectivity to us. There's no significant technical work required. For organizations that utilize point-click care, it will be a very similar process. The only additional step we have to work with them is they have to make sure that their contract with point-click care includes collective medical agreements within that. And point-click care has been working through that contracting process as they update their contracts with some of their acquisitions. For others, it's dependent on what the intent and goal of your organization is and what kind of access you want. So there's some very simple interfacing we can do that gets information flowing and provides access to our portal. We can provide access to the portal the minute you sign agreements. We do not need to wait for interfacing and the technical component to be complete for folks to be able to access our data and be able to utilize the system. And as of right now, it's not an a la carte model. So all of our services right now are included as part of our base fees. So there's no additional charges that come on after the fact for that. Oftentimes, just be aware, EHR vendors may have charges associated with external interfacing. You really have to contact your vendor to understand if there are charges and what those charges are like.
Is this process online, Ben, or do you have contact information? We're recording this, so there's going to be several.
So we will, let me start my share again here. So we've got, so there's our.
Okay, good.
Like I said, we'll send this out, so you can be able to send this whole presentation out to even for folks who are not here. We are happy to, Jack and Krista and the rest of our team, we will set up Zoom meetings with you if you'd like to do in-person meetings. I'm in Billings half the time and Helena the other half of the time. So happy to come out and sit down and talk to you and your teams if you have questions, if you'd like a demo. We really want to try to work with you and your teams as closely as possible and try to make this as painless a process as possible.
With the time that's left, I just want to ask for those of you that are on the call, if any of you have questions or follow-up questions for Ben that were asked earlier. There was some on chat. Did everybody get their question asked? And if they did, other questions that might occur to you?
I have one for Ben.
Deb's on our board, just so you guys know. Yes,
I want to know what you would like to see from Mountain Pacific and our partners and our coalitions around a potential use case for bringing in advanced care plans or advanced directives into Big Sky Care Connect. What would it take for you to make that be a potential use case that we move a little closer to our implementation plans?
There's only two things I need for that, Deb.
Money.
Money and time. We can do anything with time and money.
Great answer, Ben.
So the time part, probably I think as we've kind of looked at our strategy and where we are on use case rollout, we're probably pretty locked in with our current projects until mid 2022, depending on how quickly some of our other rollouts go as far as image exchange and some other integrations we're working on. But I think we'll be starting to look for those next use cases end of second quarter of 2022. So if there are ideas or goals that folks have as they look to work with us or partner with us, that's what we're looking for. And then it's just bring a bunch of money and then we'll be happy to do it.
Dr. Borganick, do you have any follow-up questions in terms of provider perspectives?
No, my question is more about, a big thing that we've been working on at Mountain Pacific is age-friendly healthcare in the 4 Ms. And I'm not sure how this connects with that, and would be more than happy to have a conversation offline about this, because I think, well, it's not in the works for 2022. I think it may be something you guys, Ben, you might want to be aware of as a really important resource for providers across continuum.
And I think, right, yeah, absolutely. I think our focus on the continuum side right now. So my background, for those of you who know me, this is not new. My background's in the post-acute care setting and in the senior care setting. And one of our focuses as an organization from the founding part was recognizing the need to connect information across that endeavor. It's one of the reasons our participation fees are less than $500 a year for nursing homes, assisted living facilities, and other senior care organizations. It's why we've gone out and worked to partner directly with Point Click Care to create ease of flow of information around that and make access to that information clear. It's those of you who continue to work in that environment, getting access to true longitudinal history on patients that are needing that care is almost impossible. And there's so much movement in our state of movement from rural settings to our more urban settings and transfers between organizations, and getting the historical information is incredibly challenging and makes delivering care and delivering quality outcomes really hard. And so our goal is really to be able to help bridge some of that gap. We believe the first step is just getting the information accessible. The second step will be really looking at ways we can start to capitalize on that information and help people deploy it in meaningful ways, and then look at what are the next steps of other information we can bring to bear, and other connectivities, other partners we can bring to bear that serve those folks.
There's a lot of you out there that haven't asked questions, so this is your opportunity. We have a few minutes left, and I'd like to make certain that we answer every question that's available out there. So anybody else? Jack, Ben, do you have anything else? Or Jack, do you have anything else you'd like to add to the presentation that you've made? This has been very, very helpful and very informative, and I appreciate the update.
I just say, Ben, when you share the slide deck with Dave, just include contact information if you would, direct like emails first, particularly
okay. for you and
Krista.
for Krista. Yep.
Yeah. Krista is, so our system is set up so that every provider partner that signs on with us will be assigned a partner success manager, basically their own personal account manager. And for most of you on that call, that would be Krista. And so that person oversees your entire onboarding and integration and engagement of the system. So from beginning to end and beyond that. So
okay,
we'll send that contact info.
And I'll make certain that's sent out and highlighted so everybody understands how to get a hold of Krista or whoever else needs to be contacted.
Dave, can I get the last word in?
Absolutely.
I
Actually,
just
I'll let
wanna-
Ben have the last word.
I don't, oh, that's going to be a battle. I have one more thing, Deb. Did you really want the last word? Because I'm happy to give you the last word if you want.
Well, no, I don't have to have the last word. I just want to make sure that everybody understands what a phenomenal job you have done coming on board as our CEO, and with the huge amount of work that had to be done and the progress that has been made in Montana. I'm also on the board of the Wyoming Health Information Exchange, and we've been at this for 6 years, and you have surpassed our numbers in less than 1 year. So huge kudos to you and your team. I love your presentations. I learn a little bit more from you every time. And so, I am truly the president of your fan club, and I do know how to spell your name correctly, but it's a little early and I didn't have my second mug of coffee down before I typed that
Only
in.
the one R. It's okay. You're not alone in that. So yeah, so just there were a couple of things I wanted to just, I know that the question had came. So I am happy, Jack, Krista, myself, RT, we are happy to, I know Becky, you'd asked about the coalition or other organizations to present to, would love to. We are, like I said, we're trying to get the message out. We have Deb kind of referenced, I sit in the seat that helps to coordinate stuff, but we have an incredible team. Our technical team, the work they do and the passion they have to get this service in place to support all of our providers, all of you and your teams in delivering exceptional care is what their goal is every day. And they do an amazing job of it. You know, Linda, you'd asked about advanced directives down the road. Absolutely, that is one of the key areas. We recognize the value for that, and certainly something we're considering. You know, part of our goal with state registry information, we're not necessarily looking to replace the state registries, but just provide the user interface side to it so that it makes it a lot easier for folks to be able to access information through kind of a single portal point. So we're working on a number of those.
Sorry, Ben, this is Catherine Borganick again. I'm a physician and I've worked with advanced care planning and started posting in the state. The advanced care registry, I think I'd be really careful about because there's no quality control. And I just sent you an email saying I'm more than willing to talk with you offline about all the ins and outs of this, because while it's really important to have it on your database, I think it needs to be done with a certain amount of forethought, which is not how the registry has done it. So,
oh, it's been, I've had the joy of working through this issue for several years. So
yeah,
we absolutely no, so saying we don't want to replace registries, we will if it's needed.
it is.
Our intent is not coming into this to replace things that work well.
Yeah.
If they don't work well, we certainly have a platform that is, you know, is intentionally built to be expandable. You know, we're putting in the basic foundation level right now, and kind of the main thing we need is we need more people across the continuum to start to jump on board. Yeah, I think Billings is a phenomenal market right now to do that, because when we get to the first of the year, we will have data flowing in from all the 3 major medical providers in Billings, Bighorn County participating. We have information flowing from the Billings Clinic regional affiliates in Columbus, Red Lodge, Big Timber, Roundup. So we'll have a really, really robust set of data for those of you who practice in kind of the South Central Montana region. So it's a great time to look to jump on board and start to work with us, and we'd love to make that happen for you.
And we'll let you have that as the final word, Ben. It's past 8 o'clock and I told everybody we'd be done at 8. So Ben, thank you. Jack, Krista, thank you for joining us this morning. Well done. For those of you, remember our meeting in November will actually be in December, because the 4th Thursday, I hope you're enjoying a nice Thanksgiving with your family. So with that, we will adjourn, and Ben and team, thank you. And I'll make sure I send the information out along with the recording. Good day to everybody.
That'd be great.
What you do.
Take care, everybody.
Have a great day.